We just went through a ton of testing concepts. Let's hammer it out with a case. You're seeing a 60-year-old male with a 10-day history of a phlegmy cough.
One possibility we're thinking of in this case is pneumonia, so we'll apply several tests to the case to assess for this possibility. Starting with our history questions, right? We might ask things like, do you have a runny nose? Do you have a sore throat? Do you have any known sick contacts in the home? People you've been in contact recently that have been ill as well? Any headache? And the list goes on. Let's see he answers yes to these particular questions. We pause and ask ourselves, do these tests actually help move the needle on whether pneumonia is more likely? Not really, right? Because it could be a manifestation of many other conditions. We see runny nose and a headache, etc., and things like bronchitis or the common cold. So we know we have to test further. He gives us a bit more information. So he mentions that he started a new medication for his reflux disease. He also got his flu shot a couple of weeks ago. So now he's asking us, are these the factors that have made me sick? So again, we have to stop and pause and figure out whether this is relevant information or irrelevant. Next, we go on to perform our physical exam and we see that he has a fever. So this is a pretty helpful data point because we know that with a common cold or even bronchitis, typically people don't have a fever 10 days out. So might be more likely pneumonia, but we still haven't cinched that diagnosis yet. So next we go on and listen to the lungs and we realize that he has crackles in his left lower lobe. Okay, so this is a pretty high yield test, especially compared with the previous history questions, because we know that in this clinical context, crackles can be associated with a possible pneumonia. You can see in that example that we didn't use a single test to diagnose pneumonia, like hearing the crackles. We used a combination of tests from the history, the physical exam, and incorporated disease prevalence factors like older age and flu season, while weeding out the irrelevant facts like the reflux medication and the flu shot a few weeks ago. All of these data points led us to that most likely diagnosis of pneumonia. Now, let's say we treat the patient with, say, a course of antibiotics, but he comes back 3 weeks later and isn't feeling much better. Using treatment as part of your diagnostic approach also helps you determine whether you have the right diagnosis. In other words, if the treatment is working, we know we have the right diagnosis. But if the treatment or treatments aren't working, that's an important time to revisit the original diagnosis. Could it be something else? Or could it be multiple diagnoses playing into that patient's presentation? Which brings us back to Hickham's dictum, which stipulates that patients sometimes present with multiple diseases at once. So in our case, the patient still has a phlegmy cough, he has general malaise and severe fatigue. We also learned that he's been smoking cigarettes for the last 40 years. Given this new information and persistent symptoms, we know we have to go digging for other possible diagnoses. Things like atypical pneumonia, maybe COPD, or perhaps even lung cancer.
My last point is to be cautious about overdiagnosis.
Overdiagnosis occurs when a patient receives a diagnostic label that may have never actually caused them harm. Like if a test identifies an abnormal finding that doesn't actually explain the patient's symptoms. For example, musculoskeletal care is plagued by the overuse of diagnostic tests. Up to 50% of all imaging tests for MSK complaints are considered inappropriate. Things like low back pain, shoulder pain, knee pain are all prone to overdiagnosis because of the high prevalence of asymptomatic structures or abnormal findings seen on imaging. For example, if a person is being seen for chronic knee pain, they may receive a knee ultrasound that shows degenerative meniscal tears, but that might not be the true cause of their symptoms. Overdiagnosis can lead to downstream effects of unnecessary further testing, treatments that may cause harm, and overprescription of medications. So, in short, more testing doesn't always lead to better patient outcomes. We always have to ask ourselves whether a particular test will give us useful information to guide that patient's treatment plan. Bottom line, tests help adjust our probability of disease. It's important to incorporate disease prevalence when we're assessing patients, and we have to have a solid understanding of test characteristics along with their pitfalls. Most importantly, we always have to correlate test findings to the patient in front of us. Ask yourself, do these results make sense for this case? We'll do deep dives later on in the course on how to become an expert at applying and interpreting tests to get to that right diagnosis.